Before we go any further, I want to tell you what this video is not. It is not a supplement company trying to sell you something new. It is not a scare piece designed to make you throw out everything in your medicine cabinet. And it is not a blanket condemnation of vitamins as a category. What it is, specifically and precisely, is a clinical review of 5 supplement forms and doses that the research consistently shows are not only unhelpful for adults over 60, but are, in several specific cases, actively harmful in ways that most people taking them have never been told. And because honest information requires more than a list of what not to do, I am going to give you the specific alternative for each one, the form, the dose, and the evidence that actually delivers the benefit the problematic version promised. The supplement industry in the United States generates over $30 billion per year. The majority of that revenue comes from adults over 50. A significant proportion of that spending goes towards supplements that are either the wrong form, the wrong dose, the wrong timing, or all three, supplements that the person taking them genuinely believes are protecting their health, and that may be interfering with medications, creating nutrient imbalances, or in some cases, increasing the very disease risks they were purchased to reduce. Your intent when you bought them was completely right. The product you bought may not have been. I am Dr. Edward. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. Before stopping any supplement, particularly if you are taking it under medical recommendation for a diagnosed deficiency or condition, discuss the change with your physician. The information I am giving you is intended to improve the conversation you have with your doctor, not to replace it. Subscribe to this channel right now before we begin. This is one of the most directly actionable videos I have produced, the kind that changes what is in your medicine cabinet this week. It is free, takes 2 seconds, and every week I produce exactly this level of clinical specificity. Subscribe and stay with me. The first vitamin I would never take after 60 is vitamin E. Specifically, the synthetic alpha-tocopherol form that fills the overwhelming majority of vitamin E supplements on pharmacy and supermarket shelves. Vitamin E is a fat-soluble antioxidant. In its natural form, it is a family of 8 related compounds, 4 tocopherols and 4 tocotrienols, that exist together in whole food sources and work synergistically to protect cell membranes from oxidative damage. The logic of supplementing it seems straightforward. Oxidative stress increases with age. Vitamin E is an antioxidant. Therefore, supplementation should reduce age-related damage. The research does not support this conclusion. It contradicts it. The SELECT trial, the Selenium and Vitamin E Cancer Prevention Trial, randomized over 35,000 men to receive either vitamin E at 400 IU daily, selenium, both, or placebo. The trial was stopped early when interim analysis found that men taking vitamin E had a statistically significant 17% higher risk of prostate cancer compared to placebo. This finding, published in JAMA, is one of the most striking reversals of expected benefit in the supplement literature. The mechanism is specific. Synthetic alpha-tocopherol at high doses competitively displaces the gamma-tocopherol and delta-tocopherol forms that are biologically active in cancer prevention. It creates a relative deficiency of the tocopherol isoforms that actually have anti-cancer properties while flooding the system with the isoform that does not. More of the wrong thing does not produce more of the right effect. It produces less of it. What I take instead, food form vitamin E through whole sources, almonds, pecans, pumpkin seeds, sunflower seeds, that deliver the full tocopherol and tocotrienol spectrum in ratios that human physiology evolved alongside. If supplementation is required due to a documented deficiency, mixed tocopherol supplements containing alpha, beta, gamma, and delta tocopherols in natural ratios are substantially more aligned with the biological activity profile of food form vitamin E. Look for D-alpha on the label rather than DL-alpha. D-alpha indicates natural origin. DL-alpha indicates synthetic. The second vitamin I would never take after 60 is calcium carbonate at high doses, the form found in most over-the-counter calcium supplements, typically in doses of 500 to 1200 milligrams, marketed specifically at women for bone health. The concern is not about calcium itself. Calcium is essential. The concern is what high-dose calcium carbonate does to cardiovascular risk. A meta-analysis published in the British Medical Journal analyzing 15 randomized controlled trials found that calcium supplementation, particularly without concurrent vitamin D, was associated with a 30% increased risk of myocardial infarction. The proposed mechanism involves acute hypercalcemia following rapid calcium carbonate absorption in a bolus dose, which promotes vascular calcification. Calcium deposited in arterial walls rather than bone. The calcium goes to the wrong place. The secondary problem is absorption. Calcium carbonate requires stomach acid for dissolution. Gastric acid production declines with age and is further suppressed in the large proportion of seniors taking proton pump inhibitors for reflux. Calcium carbonate taken with reduced gastric acid absorbs at a fraction of the labeled dose, leaving a large, unabsorbed calcium load in the colon that research has associated with increased colorectal cancer risk at high chronic doses. What I take instead, calcium citrate, which does not require stomach acid for absorption and absorbs significantly better in older adults with reduced gastric acid, at lower divided doses, 200 to 300 milligrams 2 to 3 times per day with meals. Calcium citrate avoids the acute hypercalcemia associated with cardiovascular risk, combined with vitamin K2 in the MK7 form, which activates the proteins that direct calcium into bone rather than arterial walls, and adequate vitamin D to optimize intestinal absorption. The clinical picture is substantially better than high-dose calcium carbonate alone. Subscribe to this channel right now. I have 3 more vitamins, and the alternatives are the most important part of this video. Every week I produce exactly this kind of specificity. Subscribe, it is free, and let us continue. The third vitamin I would never take after 60 is folic acid, the synthetic form of folate found in most multivitamins and B-complex supplements and mandated as a food fortification additive in flour, bread, and cereal throughout North America. Folic acid is a synthetic compound that does not exist in nature. It must be converted by the enzyme dihydrofolate reductase into the active methylfolate form the body can actually use. This enzyme activity declines with age and is significantly impaired in individuals with common MTHFR gene polymorphisms, variants affecting folate metabolism that are present in an estimated 40 to 60% of the general population. In these individuals, unconverted folic acid accumulates in the blood as unmetabolized folic acid, which appears to interfere with natural killer cell function and mask vitamin B12 deficiency. The relationship between folic acid supplementation and cancer risk in older adults is concerning. The aspirin and folate polyp prevention study found that folic acid supplementation significantly increased the risk of advanced colorectal adenomas, the precursor lesions to colorectal cancer, in people who had previously had a colonoscopy showing adenomas. The mechanism is consistent with the research showing that folate promotes DNA synthesis and cell division generally, including the division of abnormal cells already present. This risk appears specific to the synthetic folic acid form in people with pre-existing premalignant lesions, not to dietary folate. What I take instead, methylfolate, specifically 5-methyltetrahydrofolate, the biologically active form that requires no conversion. For seniors concerned about B vitamin status, a methylated B complex containing methylfolate rather than folic acid, methylcobalamin rather than cyanocobalamin for B12, and pyridoxal 5-phosphate rather than pyridoxine for B6 provides the active forms that the aging metabolism handles most efficiently. The fourth vitamin I would never take after 60 is high-dose vitamin A as preformed retinol, the form found in cod liver oil, liver supplements, and vitamin A supplements typically dosed at 5,000 to 10,000 IU. Vitamin A toxicity in seniors is more common than most people realize because vitamin A is fat-soluble and accumulates in liver tissue. Chronic low-level excess produces reduced bone mineral density, increased fracture risk, liver toxicity, and immune dysfunction. A study published in the New England Journal of Medicine found that postmenopausal women with the highest preformed vitamin A intake had significantly higher rates of hip fracture than those with the lowest intake, with each 500 IU increase in retinol associated with a measurable fracture risk increase. The deeper mechanism involves competition with vitamin D. High-dose preformed vitamin A acts as a competitive antagonist to vitamin D at the retinoid X receptor. the complex through which vitamin D exerts its effects on bone mineralization, immune regulation, and cancer suppression. A senior taking high-dose vitamin A is effectively blocking their vitamin D activity at the cellular level, regardless of how their vitamin D blood level looks. The 25-hydroxyvitamin D may appear optimal. The cellular response to it is impaired. What I take instead, beta-carotene from whole food sources and supplemental mixed carotenoids. Beta-carotene converts to vitamin A by the intestinal mucosa only as needed. The conversion is demand-regulated. You cannot overdose on vitamin A from beta-carotene under normal circumstances because conversion stops when tissue retinol levels are adequate. Carrots, sweet potatoes, leafy greens, and red bell peppers provide abundant mixed carotenoids without the toxicity and vitamin D interference of preformed retinol supplements. Now, before the fifth vitamin, this is the moment to share this video. While the four you have just heard are specific enough to change something on someone's shelf today, the person in your life who takes a high-dose vitamin E, a large calcium carbonate tablet, a folic acid multivitamin, or a cod liver oil supplement every morning deserves this information. Share it with them now. Then come back for the fifth, because it is the most nuanced one and also the most likely to apply to you personally. The fifth vitamin I would never take after 60 is high-dose vitamin D3 without cofactors. Specifically, vitamin D3 supplementation at doses of 5,000 IU or more per day, taken without concurrent vitamin K2, magnesium, and attention to calcium balance. I want to be clear, vitamin D deficiency is extremely prevalent in seniors. An estimated 41% of American adults are deficient, with higher rates in those who are indoors more, have darker skin, or live in northern latitudes. The benefits of correcting vitamin D deficiency are real. I am not saying do not take vitamin D. I am saying the form in which most seniors take it, a large dose of D3 alone, without the cofactors that determine where the calcium it mobilizes actually goes, is creating a problem while solving one. Vitamin D increases intestinal calcium absorption substantially. At doses of 5,000 IU or above, this effect is significant. The calcium that vitamin D mobilizes needs direction. It needs to be routed into bone rather than deposited in arteries, kidneys, or soft tissue. That direction is provided by two vitamin K2-dependent proteins, osteocalcin, which incorporates calcium into bone matrix, and matrix Gley protein, which actively removes calcium from arterial walls. Both require vitamin K2, specifically MK7, for activation through carboxylation. Without adequate K2, calcium mobilized by high-dose vitamin D has no routing mechanism directing it toward bone and away from arteries. The result is the finding that has surprised clinicians in high-dose vitamin D studies: arterial calcification on imaging combined with suboptimal bone density despite high vitamin D blood levels. Magnesium is the second missing cofactor. Vitamin D cannot convert from its storage form, 25-hydroxyvitamin D, to its active form, 1,25-dihydroxyvitamin D, without magnesium-dependent enzymes in the kidneys and liver. Seniors supplementing vitamin D without adequate magnesium are not converting their supplement into the biologically active hormone that produces clinical benefits. Their blood level may appear optimal. Their tissue activity of active vitamin D is significantly lower than that number suggests. This is why some seniors supplement vitamin D aggressively, maintain apparently adequate blood levels, and still fail to show the bone density, immune, or cardiovascular improvements that vitamin D research predicts. What I take instead, vitamin D3 at a dose calibrated to achieve 50 to 70 nanograms per milliliter of 25-hydroxyvitamin D on blood testing, taken with 100 to 200 micrograms of MK7 vitamin K2 and supported by magnesium glycinate or malate. The dose of D3 required varies enormously between individuals based on weight, pigmentation, sun exposure, and gut absorption, which is why the target blood level rather than a fixed milligram dose is the right metric. Test, supplement, retest at 3 to 6 months, and calibrate to the result. Here is what to do in the next 48 hours based on what you just learned. Today, look at your supplement bottles. Check for DL-alpha tocopherol on your vitamin E label. That is synthetic. Check for calcium carbonate on your calcium. That is the form linked to cardiovascular risk. Check for folic acid on your multivitamin or B complex. That is the unconverted synthetic form. Check for preformed retinol or vitamin A palmitate in doses above 2,500 IU. Check whether your vitamin D3 has K2 and magnesium alongside it. Write down which of these applies. This week, request a blood panel from your physician that includes 25-hydroxyvitamin D, serum calcium, folate, and B12. These are the levels that tell you whether you have a genuine deficiency requiring supplementation or whether you are supplementing on assumption. At your next appointment, bring your supplement list with doses and ask your physician to review each one for interaction with your medications. Most physicians welcome this conversation when the patient arrives prepared. You now know that taking a vitamin is not the same as receiving the benefit it is marketed to provide. The form determines whether it converts. The dose determines whether it is safe. The cofactors determine whether it goes where it is supposed to go. And 5 of the most commonly taken supplements by seniors over 60 fail on one or more of these criteria in ways that have documented clinical consequences. Now you know which ones, why, and exactly what to take instead. Subscribe to this channel if you have not already. My next video covers the 5 supplements that the research most consistently supports for adults over 60. The specific forms, doses, and timing the clinical evidence actually validates. That is the companion to everything today opened. Subscribe so it comes directly to you. I am Dr. Edward. What is in your cabinet should be working for you. Now you know how to check. I will see you in the next one.